Well, hello, I'm Dr. Crispin Simmons, and I'm here today with Dr. Robert Jankelson, one of our iconic figures in dentistry, and certainly one of the most iconic figures next to his father, Bernard Jankelson, in what we generally refer to as neuromuscular dentistry. And so Bob's agreed to chat with us a bit today. I took him out of his normal role here as the wine master of Chelan, and we're here in this beautiful restaurant here up on the mountainside, surrounded by the vineyards. So he's taken a few minutes out today to revisit with us some of the basic concepts of neuromuscular dentistry, and I've asked him also to focus on ultimately going to lay some groundwork for you. Many of these things most of you do not know, because you've never been exposed to it. But I've also asked him to lay the groundwork for the concept of myocentric, and then beyond that, how important that concept is centrally to what we do in dentistry. So, Dr. Jankelson, tell us a bit about the original process.
Okay, well, first of all, Chris, I want to thank you for carrying on the legacy of my clinical practice in Seattle. And you're one of my longtime early students, goes back 44 years, I believe.
Correct.
And my neuromuscular career goes back almost 60 years. And it began with my father, who, my mother, in explanation, had multiple sclerosis. And so what most people don't know is my father, often referred to as Dr. J, became very involved and world famous in research on multiple sclerosis. And after 20, 30 years, he was working with some other doctors, primarily University of Oregon, that were also involved with multiple sclerosis research. And the whole idea that led to neuromuscular dentistry began with the concept that they thought that because MS is an issue of neural transmission inhibition, that if you could hyperoxygenate the myelin sheath, which is the conductive component of the nerve, that you could then increase the neurologic transmission. Well, this didn't work quite as planned for MS, but what they found is that the use of TENS, low frequency, ultra low frequency TENS, could create an involuntary contraction of a neurally mediated stimulus that will cause involuntary contraction of all of the muscles innervated by that nerve.
Correct.
And so what was happening? Well, when we are dealing with patients in chronic pain, doesn't matter whether it's the head and neck or whether any other part of the body, you're dealing with muscles that are shortened, muscles that are hypertonic, meaning that at rest they just can't relax. What happens is basically, very simply, the myosin and actin fibers bind up and they can't relax. They can't get back to rest. When you have a patient that is in pain, TMD pain, they are in a state of sustained contracture. And they can't get out of it.
It's a chronic condition at that point.
That's right. So at some point, you have to figure out how are you going to intervene in that cycle of pain spasm. And yeah, sometimes you can luck out, make a non-quantitative split, and it'll help the patient. But that's not science, and that's not good medicine. Okay?
It's luck.
Sometimes luck, yes. Now, let's go with the principle of TENS, because the TENS was developed before EMG.
Correct.
We noted empirically that patients were getting better with the myomonitor. And when we put them in this path of closure that the myomonitor stimulated, they got better. But we didn't have a really solid scientific explanation.
And you couldn't quantify it.
You couldn't quantify it, that's right. But we knew something good was happening. And that let's say, was 1965. And I was doing clinical dentistry at that time, and my father was a prosthodontist, in prosthodontic practice, and we noticed that with our full denture patients, by the way, full denture patients don't have that much TMJ, do they?
No.
Because what happens is the denture is loose enough, the jaw just moves forward out of its CR, artificially retracted pathologic position.
Correct.
But
They just wear the teeth into a
that's
place.
that's correct, and the denture base just moves with it. And they in those days they had something called post-insertion syndrome. You push the jaw back and take the bite, and then you spend a week or two adjusting the occlusion forward. That's right. All of a sudden, when we started taking the tense bites, there was no such thing as post-insertion adjustment.
Right.
It just, everything was fine. And so we knew we were on to something. So now the rest of the story, as Paul Harvey would say, along came something called EMG, which really increased our understanding of what truly was happening. Prior to about 1979, we had to do our EMG studies in a Faraday copper cage. This wasn't practical clinically.
Right.
In 1979, the U.S. military had all the algorithms for canceling the Earth's magnetic field, which is the reason you have to have the Faraday cage.
Correct.
And so they released those algorithms, and by that time, my father had very brilliant staff. You knew some of them, Chris. Software engineers, hardware engineers, biophysicists, and they then took those military algorithms and developed the first clinical EMG for dental use.
Yes, and I recall also that Dr. J would make these claims about the EMG, which he had researched and knew it to be a fact, but you had to do it in a Faraday cage.
That's right.
So he was challenged by a lot of clinicians around the world saying, well, how do you know that, though? This is your patient. You know that from research, but you don't know that on this patient. Well, that was another reason for him to be really
And what was
committed to
interesting,
doing.
Chris, is where, there's a lot of science never gets translated to the clinical level.
Right.
There had been studies since the 60s, a lot out of Scandinavia, Sweden, Jankelson, and some of those other famous researchers that were doing EMG studies, but it wasn't practical at a clinical level. So those studies just got left behind. Now, before we go any further, there are two basic principles, and we're going to repeat this throughout this discussion. Two basic principles about physiology. When you're at rest, low EMG is a desirable goal. In function, i.e. when the teeth come together and maximum clench, the better the occlusion, the higher the EMG levels are going to go because you recruit more muscle, more efficiency. So remember that paradigm. And it's a paradigm in not just in dentistry, in every part of the human body.
And that I refer to those types of bits of information as first principles.
Right.
They're sound beginning places to develop other thought processes and procedures.
And there's areas of medicine and sports medicine that measure the same thing with leg and arm strength and movement, better muscle recruitment at a functional position, the better you are.
Of course.
Pretty simple.
It's almost common sense.
Right. So now, let's put the two together. We have this thing called low frequency TENS, the biomonitor. And it might be good to take a little diversion here, Chris, just so, because a lot of dentists aren't familiar with some of the, the technical stuff.
Right.
There's basically two kinds of TENS. There's high frequency, and they're called pain blockers.
Used mainly for pain control.
That's right. And if you implant, they're called dorsal column stimulators. And it works on the principle that the stimuli that you're putting in there is so rapid that it goes up the neural complex, and at the midbrain level, the gate, there's something called the Melzack wall gate.
Right.
There's two types of nerve fibers, basically. There's C fibers, pain fibers, and alpha fibers. Well, fortunately, the alpha fibers are more rapid transmitters. So if you can load up the alpha fibers with good sensory information rather than pain information, you
Right.
block the pain in the cortical level.
The cortex, right.
Yeah. Now, pain is not interpreted until it gets to the cortex. And so that's the function of high frequency TENS. But low frequency TENS is very different. It is a stimulus that goes down the nerve trunk, and then all at the proper wavelength and frequency, all of the muscles that are supplied by that nerve. And think of the trigeminal and the facial. 60% of all the neural cranial tissue is in those two nerves. Those are the nerves that we deal with.
Yes.
So Dr. J said, gosh, if we can get that stimulus into the fifth and seventh, we're home free. Well, that's exactly what he did, as you know, the coronoid notch. Those two nerves come out of the pyramidal valley, rotundum.
And the pre-existing anatomy gave us a golden opportunity.
It was their, golden opportunity. And, our let's say, intellectual colleagues in the profession use derogatory terms such as jaw jerkers, because you're going to see a visual, at a certain threshold, you're going to see a visual contraction of the muscles, the masticatori and the facial muscles. So what's happening? Well, in these patients that have pain, that have dysfunction, have shortened muscle, those muscles have bound. And the pain that all of our patients are experiencing comes from a couple of different things. One is you're pinching nerves. Our nerves are going through those muscles.
Right.
And if you pinch those nerves, it hurts. But also, just as important, as you shut down the circulation, because if that muscle shortens, the blood vessels that are going through those muscles also get pressured. And you get reduced blood flow, hypoxia of the muscle. So our objective then is to do two things. Number one is to get more oxygen into that muscle. So how do you do it? You pump the blood in there, and you bypass the splitting that the patient goes through to protect themselves. And then the other thing is that you're pumping out the waste toxins that accumulate in the lactic acid cycle. So now let's talk about the lactic acid cycle versus the Krebs cycle. And for our audience, you studied this stuff in dental school, but it didn't have any clinical meaning. It actually does. Because what you're trying to do with the TENS and with that pumping of the blood into the muscle that was deficient due to shortening of the muscle and squeezing of the blood vessel, you are getting a shift from the lactic acid cycle, which is acidosis, to the Krebs cycle, and you all remember studying it, that was the normal one. So what happens? In the Krebs cycle, you can metabolize 32 adenosine triphosphate molecules. They're the ones that allow muscle to relax.
That's the most optimal.
That's right. But in the lactic acid cycle, there's only 8. So the idea is it's generic, Chris. We think this is dental stuff. It's not. I mean, it's all common physiology.
All mammalian physiology works the same way.
Right. And if you told a physiologist or physician that your goal is to squeeze stuff together, he's going to look at you and say, "You're crazy." But that's what we've been doing with our concepts of CR.
Right.
So now, let's take it the next step. And that is that as you relax the muscle, and muscle gets longer, it's going towards a state of rest. And so how do you know? Well, how do you know? Anybody use EMG? If you don't, you don't know. You can guess it, but EMG will tell you.
You're just asking if the patient feels better.
Yeah. And so with EMG, you have a quantitative measurement of whether you're going in the right direction or you aren't. And that's incredibly valuable. So now let's morph into this concept of myocentric. Okay? And it starts not with the myocentric, but somewhere out here in space, there's a 6-dimensional place that will reflect the minimal electric activity at that position. Meaning, when you are at the position that is minimal electrical activity, the jaw is just relaxed.
Right.
That's going to be rest. That's your starting reference point. And there are 6 dimensions. People don't understand. Dentists don't understand. They think 3-dimensional. You know, you think of vertical, retrusion, protrusion, and lateral. But you also have the issues of torque. And so the mandible can torque like this, which is going to cause muscle imbalances. So if you, let's say you're hitting high on one side and you're compensating, you're going to have an imbalance of muscles bilaterally.
Right.
And that's not what you want.
No.
So your goal, I would think, would be to be to see EMG rest levels. Let's start to level out bilaterally and go lower. Is it that complicated? Not really.
Not really.
Not if you could measure it. But if you don't measure it, and Dr. J had this famous saying, I think Dr. Simmons probably was raised on this mantra. If you can measure it, it's a fact. If you can't, it's an opinion.
Right.
And we've had way too many opinions in dentistry, not enough facts. The facts are there, it's in the literature. Unfortunately, the literature didn't translate to the clinical as it should have.
Right.
And also, it didn't get integrated with the mainstream medical literature. If you read the mechanical approach to dentistry over the last 100 years, and my career spanned 60 of those years, you would swear dentistry was a mechanical profession.
Biomechanical only.
Yeah, it's not. We deal with the same physiologic principles that apply to every physical therapist, every osteopath, chiropractor, physician deal with.
The same orthopedic principles.
It's all orthopedic. That's
All
correct. Yeah. And we are trying to restore postural integrity. Take that word to the bank.
So now we have discovered fundamental basics for all this. And so we have the concept of myocentric occlusion or trajectory, or there's several different related terms.
Now, let's talk about myocentric, because the start of myocentric is identifying this rest. You don't want to start with the teeth are together.
Right.
You want what we loosely say freeway space. Oh, I'm going to have to take a sidetrack here, because if you have not used TEMS, you are dealing not with freeway space, you're dealing with accommodative freeway
Right.
space. The patient is in pain and structural dysfunction.
An acquired position.
That's an acquired position where they'll try to hold the jaw closer to tooth contact. So they can have 8 millimeters of true freeway space, but they're going to hold it within 2 millimeters.
Correct.
And you're going to interpret that as
Normal.
normal. And so until you do 2 things. Number one, you bypass those physiologic pathogenic mechanisms that are causing the problem. And then you measure. Until you do that, you're just guessing.
Again, as we always do.
Now, let's talk about the rest of the story. So here you are, rest position, documented with EMG, the lowest possible position you can find in space. Now, our objective is to somewhere intercept a path of occlusion that is going to reflect the minimal amount of energy. And take this one to the bank. The minimal amount of energy expended going from rest to terminal occlusion, terminal centric, is your goal.
Correct.
I repeat that. There is, in fact, a tunnel in space from rest out here, upward, through which the mandible, and it's not just a line, it's a little forgiving tongue,
Right.
but not very much. Not very much diameter there. And at some point, you're going to determine where, let's say they have a pathologic centric, and they're suffering, and they've got all the syndrome and symptoms of TMD. You have to identify a stop position in that neutral tone.
Right.
So look at this trajectory, this path upward, as a neutral tone. You generate that after you've relaxed the patient by the involuntary movement generated by what? Tense. Because it's going to follow the path of, if you will, least resistance, least amount of energy to get from point A to point B.
As long as you're not bringing the teeth together.
That's right. Now, our problem as dentists is we have this very unforgiving environment called teeth. And they're hard, they're not forgiving,
No,
and
they're sensitive.
yet another principle of neuromuscular dentistry is that there are three components. You've got the muscles, and the muscles will go wherever the teeth dictate.
Correct.
The teeth are another component, and they're unforgiving. You're always going to go to the most stable position, whether it's painful or not, whether it's causing pathology or not, because that's your endpoint. So now you have to determine a point along which you intercept that neutral tunnel of closure. And so now you have some judgment. You can't go right or left too far. You can't go front or back too far because you've got to be in that neutral tunnel. But do you give them 5 millimeters from rest? 1 millimeter? 2 millimeters? Well, typically 1 to 2 millimeters from rest position until the teeth contact. That is a clinically determined position. And why do you say 1 to 2 millimeters? Because we go back again to general medicine and physiology. When you're walking up stairs, you don't goose step, lift your foot 6 inches above the next stair and plant it, and lift yourself up another 6 inches above and then plant that one. You conserve energy.
Right.
Why is occlusion any different? Why are jaw muscles any different? So if you're having to close through 8, 10 millimeters of freeway space with a gross overclosure, it's a waste of energy.
Right. And everything about how our bodies function is directed to conserve as much energy as we can.
These principles, Chris, are so elegant, and you're absolutely correct. It's not brain surgery, as they say. But we should go back to the textbooks that we thought were just hurt us to get into real dentistry. The biochemistry, understanding the Krebs, lactic acid cycles, understanding conservation of energy as a general principle of any biologic mechanism.
System.
That's right, any biologic system.
Right.
And so these are some of the foundations of neuromuscular dentistry.
And then beyond being able to measure, a very difficult thing for people to do is to gain experience and judgment with what are your possible parameters. Because rarely do we get a person that's perfectly on trajectory, that's perfectly 1.5 millimeters. They have an accommodation zone, I guess you'd say.
And we probably should
We
introduce
try to always get perfect, but
the third modality. We've talked about the TENS, we've talked about EMG, but then there's also jaw tracking. And that allows you to see a digital display of jaw movement and closure. And it's also correlated with EMG levels at any given position. So you can, at any one time, any position in space, look at what the EMG levels are. Which brings us to another simple principle of neuromuscular dentistry, which is no different than general physiology. The principle, again, is that when you're looking at rest, down is good, low EMG levels, you're conserving energy, and the body's recovering its metabolic energies. But then, when you hit a functional point, you want that position to be able to generate optimal muscle recruitment, meaning optimal fibers being recruited.
I always think about the analogy of the heart. When it beats, it doesn't partially beat. It beats, and then it goes into total rate.
Right.
And it will do that, of course, for our whole lives. But if it didn't do that, if it behaved like a muscle with a patient with TMD, you would die within 8 or 10 minutes.
And not to be dramatic, Chris, but a lot of our patients are slowly dying because chronic pain
It's killing you.
kills you. You just don't have the massive coronary.
Right.
And it was interesting. I just got I've been retired a long time, as you know, got a lovely note from a former patient just before you took over the practice in 1991. She'd been injured in Iraq, Lady Marie. And I hadn't remembered her for 30 years. I get this note. Dr. Jankelson, thank you for saving my life. Well, we're dentists. We don't save lives. Yes, we do. She said, when I came to you, I was desperate, ready to commit suicide, in constant pain, and I tracked you down. I know you have a winery now, and I just wrote you to thank you for saving my life. Well, that's pretty special. Her name was Julie. You may even see her now. I don't know. But,
Well, that's why we do what we do, Bob. And we were speaking earlier about the fact that my generation and those before me, for at least 2 decades after I became involved, there was never a discussion about making money via neuromuscular concepts or techniques. It was just about being the best dentist you could be, and it helped you tremendously. And then you would, because you're the best dentist around, you would make more money.
But I kept, Christian, I would apply this to you, but I think we could make a generalization that may be presumptive, but to be a good neuromuscular dentist, you have to care more than the average dentist. And the average dentist cares a lot, but you gotta care. I mean, you gotta put your heart and your soul into your patients. And often diagnostically, it's like peeling onion skins. These patients with chronic pain come to you after you may be the 20th provider, and you're having to peel back all of the possibilities. But the fact that we have measurement capabilities, you can document. No different if you go to the physician and doing the blood panel, he says, oh, you got your liver panel's off, or your kidney panel's off, on and on. That's what we do in neuromuscular dentistry. Now, a lot of our patients have a lot of other stuff going on.
Correct.
But what we know is that we can measure pathology versus non-pathology with the masticatory magnetic system. And so that's what we focus on. I mean, we don't treat some of the other stuff that's bugging our patients. We refer a lot of patients for ancillary care with other healthcare providers. But our job is to document and treat abnormalities, dysfunctions of the masticatory system, pure and simple.
And we have a huge advantage in being able, as I often will talk to my patients, and I let them know that, yes, I can't manage all these other problems, but I can know when I've dealt with this. I can know that. And
yeah, and you have, that's the other
they
thing.
can move on with their life and deal with these other issues rather than going to 30 different dentists.
And also, it keeps you honest, because I can't tell you how many patients that I've had that it wasn't quite there. Normally you'd say, oh, that's good enough. But you knew it wasn't quite there.
That's good enough.
And then you'd run your standard test, EMG test, jaw tracking test, and you see a little tweak. And sometimes we're dealing with microns.
Correct.
I mean, you just, there's one little prematurity, and it creates issues beyond anything you could imagine. And you identify that with your technology, and all of a sudden, the numbers look good. The patient's eyes light up. You can tell, Chris.
Oh,
You've been in it a long time.
They
When
say
those patients-
immediately they know.
When those patients' eyes light up, you know you hit the magic button.
You can't do that with a,
You
with
can't.
a 14 millimeter piece of wax paper.
That's right.
Correct. Well, Bob, thank you, and I know all the folks that are going to watch this are going to be impressed with your knowledge and your ability to be able to explain this in an easily understandable way. And I certainly appreciate you taking the time, and we're glad I have this on video. We did this once before some years ago, and it was amazing, but we thought you were maybe going to talk for 5 minutes because you were so busy. But now I can look at this anytime I want to, and I can get the lecture again.
And for those of you that are getting into neuromuscular concepts and technology, it seems complicated, but it's not. The principles are so basic and so simple. Yeah, the technology may be a little more complicated, but the concepts are the most elemental concepts in medicine that you could imagine, in physiology and biochemistry, and all those things that we thought it was a stepping stone to real dentistry.
And like you said, the instrumentation keeps you honest.
It does.
You'd like to not see sometimes what you see, right?
Exactly.
But then you just have to double down and figure out why it's there. Well, Bob, thank you so much.
Thank you, and
very happy holidays to you.
may all of your disciples find the joy in neuromuscular dentistry that you and I have.
Thank you so much.